Is Sophie Boivin, and really excited to be here on behalf of IPT-HOPE. I am a physiotherapist from Canada. I'm living in British Columbia. Just as we are waiting for people to come in, feel free to post in the chat kind of where you're from or what you're looking forward to about this webinar. I think we have people from all over, so just out of curiosity, it'd be interesting to see where everyone is from. So go ahead and do that. And while you do that, a couple housekeeping notes as we begin. So if everyone could have their cameras off for the duration of the presentation, as well as their microphone muted, just to kind of prevent those distractions. As well, we'll have a question and answer period kind of at the end of the presentations. So feel free to post your questions in the chat, or at the end, we'll ask you to come on the mic in order to ask our questions. As well, this webinar will be recorded, so that everyone is aware. The webinar should take approximately an hour. We'll kind of go through an introduction, background information, insights from Dr. Ofek's feasibility study, and a case study to kind of finish it off and allow for real-life application. We'll give it a couple more minutes, maybe one more minute, and then I'll do kind of an introduction of the speakers, and then we'll begin. All right, so we have Dr. Ann Newstead, who is a physiotherapist from America and owns a private practice in Texas with the focus on older adults. She's a certified specialist in geriatrics and neurology and has her certification in vestibular rehab. She has published research in the area of yoga, balance, falls, older adults, and brain injury, and is currently the secretary of IPT-HOPE and the liaison to the Academy of Oncologic Physical Therapy. And then we have Dr. Hades Ofek, who is a neurophysiotherapist with 27 years of clinical experience, as well as management experience in stroke, spinal cord injury, and traumatic brain injury units. She's also a lecturer at Zifat Academic College in Northern Israel, with her research fields including sensory rehabilitation in subjects with acquired neurological disorders and central neuropathic pain. And her current research involves chemotherapy-induced peripheral neuropathies, which we'll discuss in this webinar today. So please welcome our speakers, and let's begin.
Thank you, Sophie, for this introduction. I'll share my... Okay. Can you see the slide? Yes. Thank you, Elena. Okay, so I saw someone from the Netherlands saying it's King's Day. That's very exciting. I used to live in Holland when I was a kid, and I remember it was Queen's Day. So now it's King's Day, which is wonderful. So have a nice holiday. I'm trying to see how that's better. I want to thank, before starting, I want to thank my colleagues who are working with me in my lab, my staff mates for this research at Shamir Medical Hospital or Medical Center. And we're going to start with our patients. We're going to start with the people, with individuals who live with chemo-induced neuropathies. And this saying is out of an article that talks about chemo-induced neuropathy, where one said, "My doctors care more about my tumor than about me." And I think we as physios are not that busy with the tumor, but sometimes we need to remember that quality of life is as important as other things. And really the chemo-induced neuropathy has to do with both balance that Dr. Ann will talk about later, and quality of life. So this is going to be like in our heads for this time for this talk. About chemotherapy, we won't talk, but we will talk about the secondary damage of chemotherapy. So people during chemotherapy or after will have secondary damage of chemo. Chemo takes care of the tumor, but on the way, we have many secondary damage in many ways. Okay, so we have the cardiovascular and the pulmonary and dermatology and fatigue and all kinds of things that we will not talk about now, but we will talk about the neurological secondary damage, which can be secondary damage of the central nerve system with brain volume reduction, with neuroinflammation, with blood-brain barrier disruption, resulting in what we call chemo brain, with memory problems and concentration difficulties and slower processing and fatigue. But we won't talk about that either. Okay, so I'm framing it within people with cancer or post-cancer already in a remission state, where they got treatment with chemotherapy, they have secondary effects, they have neurological secondary effects of the central nerve system and of the peripheral nerve system. And we'll go into that. Well, we have there the peripheral neuropathy. So it actually puts us in place. We're talking about chemo-induced neuropathy, which is a secondary effect of chemotherapy, a neurological secondary effect of chemotherapy. Okay, that frames us into place. This is a patient where the main thing he said, I'm moving my toes all the time because I have paresthesia. Paresthesia is tingling or weird sensations there in his feet and his toes. And he says, it's a problem. It wakes my wife, so I try not to do it. I'll show you what he keeps doing all the time. He keeps doing this, okay? He keeps moving his toes. And what he says is, I want to sleep in my bed. I want her to sleep in our bed. She, I in treatment all the time. I'm with fatigue. She works, she takes care of the kids, she takes care of me. I just want her to sleep at night, and I don't want her or me to have to move to another room. So it's a very functional, specific, individual quality of life type thing that this man says, please help me with that. Okay, so we might see it, we want to take care of a tumor, we want to take care of cancer, we want to keep him alive, we want him to walk better, we want all kinds of things for him. What he wants is just to sleep and let his wife sleep in their bed. And that's like, I'm going with that, okay? So what is chemo after putting it in a, a private way like that, in an individual, in a more way like that, we'll go more to the general and then into that. So chemo-induced peripheral neuropathy, CIPN, is a neurological complication of chemotherapy. It is mainly sensory. We'll say later that it can be also motor and autonomic, but it's mainly sensory. It affects, depending on literature, depending on the study, 50 to 90% of patients who receive chemotherapy. With the neuropathy can last just a little bit, but it can last for years post-therapy. With, again, we have a very wide range, but by literature, 11 to 80% of people who had chemo-induced neuropathy will have it 1 to 3 years after chemotherapy has stopped, and 50% even after 5 years. So depending on the study, but it gives us a picture of how wide the problem is, or how many of our patients really suffer from that. And it's a hidden problem. It's not talked about much. you know, they're happy they got care for the tumor, but that CIPN is really a very big burden on life. It can worsen with chemotherapy dose, and it worsen with types and mixes. And it may start after chemo ends. That is called coasting. So someone gets chemo, and then a month or two after chemo has stopped, suddenly there's tingling, there's balance problems, all the things we will talk about, hypoesthesia, that is coasting, and that is due to chemo. And that's also something we need to know. If we treat someone who had chemo a few months before, and suddenly the things we will talk about now appear, we should have that as a, you know, thing that might be CIPN. The mechanism of damage in CIPN, it varies by chemotype. We have here all kinds of different taxanes and thalidomide and others. We won't talk about the specifics of different toxins that are given, but what we see is a length-dependent axonal degeneration. We call it dying back neuropathy. So we see distal to proximal. It's because there is a length vulnerability. The nerves, as distally as we go, have less nutrients. They have less ability for regeneration, and the body, the first to be hurt are the distal nerves. In addition, there is dorsal root ganglia involvement with a neuronal mitochondria dysfunctioning, which also hurts the peripheral nerve. And both in the peripheral nerves and in the spinal cord itself, in the dorsal horn, there is a dysfunction in the ion channel, and therefore the sensory data or sensory input gets not up. We can't receive it as well. There's the nerve system does not work that well. So what we see after that damage will be mainly distally, mainly sensory symptoms. There could be sometimes, as I said, motor and autonomic involvement, but it will be mainly a symmetric glove and stocking pattern. So with really lost sensation or more diminished sensation distally in the toes and fingers, and then gloves up to wherever. I've seen patients up to the mid-thigh even, and sometimes diminished sensation around the sternum or the midline of the thorax and abdomen. What are the sensory symptoms? Okay, we said it's mainly sensory. So what are the sensory symptoms? They're mixed signs. We have negative and positive, which both are negative, okay? Then none of them are good. But the negative are minus signs. We have hypoesthesia. They have decreased sensation of touch, of proprioception, of temperature, of vibration. All sensory modalities are decreased. And they have hypolgesia, which means if we give a painful stimulus, they'll feel it less than we would feel elsewhere or proximally or for someone else. But with that, and that's a paradox, okay? We have the paradox word here. With that, they'll have positive signs, positive meaning plus signs, okay? They're not positive in any way, shape, or form, but they'll have hypersensitivity to cold, to touch. They'll have paresthesias, as we say, tingling, little shocks, all that. They have dysesthesias, which are paresthesias that actually hurt, like electric shocks, or tingling that is not tingling, but is rather needles. They'll have hyperalgesia. So we have hypoalgesia, and they could have hyperalgesia, okay? They'll have allodynia, which means that things that usually, or sensory stimulus that usually don't hurt, will suddenly hurt. Someone touches them and they hurt. They put their foot into cold water, which usually would just be cold, and it really hurts. The the cold floor if they walk bare feet hurts, etc. And they have spontaneous neuropathic pain. So all this is this bag of neuropathic pain. They have peripheral neuropathic pain with all these signs and symptoms, and with this paradox. They have hypoesthesia, but on the other hand, they have paresthesias and allodynias, etc. From a functional point of view, they'll have impaired balance, mobility, and gait. Their touch is diminished or less. Their proprioception is diminished or less or lost. And the balance decrease will turn into that they have twice as much the risk of falls than healthy, the same age, etc. The severity of CIPN correlates with number of falls. As severe that the CIPN is, as more diminished or lost the sensation in the feet is, the number of falls will increase. In addition, they have fine motor challenges that we won't talk about today, but that are important and that we should, as physios, address and treat, and sleep disturbances, which is something to know, and that's part of their decrease in quality of life. Treatment, apart from the sensory treatment that we'll talk about later, duloxetine is the main, or the gold standard pharmacological treatment right now. Exercise, there are a few studies that have shown that exercise from different sorts works, different, but really first studies that show that. Electrotherapy, TANS, ultrasound, a few studies, and acupuncture, capsaicin cream, again, all those, exercise, electrotherapy, and the acupuncture, capsaicin, just a few studies, just to start to see what we do with these people. And of course, we can address them with functional task-specific therapies that will see how they adapt for adaptation, for compensation, for these neuropathy effects. But I'm sure we'll talk about that later, and we'll talk about that later. Important considerations that chemotherapy may cause dose reduction or cessation. So sometimes doctors need to stop or to change chemotherapy because of CIPN, because it's so hard on the patient. Early detection and monitoring can improve treatment management, and patient-reported severity often differs from physician assessments. Sometimes physicians will say it's minor, and then when we'll ask the patient, it'll say it's major, and it really, really bothers my quality of life. So that's something we should ask about and be aware. I'll stop sharing, and I'll pass you on to Dr. Ann Newstead, and then I'll be back after her talk. Thank you.
Okay, thank you very much. And now I am going to share my presentation. All right. So this portion of our talk today is on mechanisms of balance, and all of us are seeking balance in our lives, and our patients in particular with the effects of chemotherapy on their balance are seeking balance every time they move through their world. And this is an extremely important topic. We know that balance is a combination of areas. It is controlled mainly in our sensory input from the vestibular system, or our true blue system, and our inner ear, through our vision, and then also through our proprioceptive system and our ankles, knees, hips, and the sensation in our feet. all of this information is integrated in our brain, not only in the cerebellum, but also in our cerebral cortex. So our bodies are interpreting every movement that we make throughout the day. And this is especially important with our patients who are trying to move and perform functional activities and maintain their quality of life. And so this information is then integrated into the brain stem, and the output is through our eye-head coordination or our vestibulo-ocular reflex, maintaining a constant vision through our world as we move through our world, through our motor responses and our protective and equilibrium reactions or vestibulospinal reflexes, and then also to bringing about the combination of these so that we can react or interact with our environment, such as using motor strategies. For instance, an ankle strategy would be a slight sway forward and backward if we are just a little bit unsteady. A hip reaction would come in more if we're standing on, let's say, a 2x4, okay, or a bus that's moving and we have more perturbation of our environment and of our center of mass. And then a stepping strategy would occur if we have more of a response to a larger perturbation. And a step is really what I consider the last line of defense before a fall. And then weight shifting is sort of where we kind of adapt and move as if we're on a boat or on a bus or on a train, where we just kind of shift our weight side to side or forward and backward. And lastly, suspensory strategy is where we use a motor response that brings our center of mass lower. When we can lower our center of mass, we're more stable and hopefully less likely to fall. But we all know that really motor responses or strategies are more a combination of all of these. Depending on the quantity of the perturbation, then we will react. The challenge, though, of balancing comes with our patients who have the effect of either aging systems, such as aging vision, vestibular, and somatosensation systems, in conjunction with their sensory changes because of the toxicity of the chemotherapy drugs. Chemotherapy medications can affect the vestibular system as well as the peripheral sensory systems that has been discussed earlier very nicely. And from a functional standpoint, then, the combination of aging as well as the cancer toxic medication effects and disease processes can lead to reduced mobility and potential for increased falls. On a developmental perspective, we know that sensory motor systems evolve as the child moves from infancy to adulthood. And all of these systems become integrated and are useful for balance, including the vision, vestibular, and somatosensation systems. So the guidelines then for improving the balance system include not only strength training and flexibility of the joints that are involved, but also actually task-specific training for balancing both statically and dynamically, plus aerobic training that can help with getting more blood flow and endurance of the muscles that we're going to be using, or that individual is going to be using to maintain their functionality throughout everyday life. One other area that seems to be efficacious for patients is providing them with some stimulus to their feet and ankles and lower legs, because many patients seem to benefit from the effects of massage. And if we have time, I'll go into a little case study of this where this is true. So the guidelines for exercise include starting easy, moving from a very closed environment to a more open environment. So easy, holding on to a rail or a surface and moving to not holding, moving from eyes open to eyes closed, and then moving from a firm surface okay, with the feet maybe together to a foam surface, with the feet maybe more tandem or single leg stance. So gradually moving in from static to a more dynamic environment where they're moving through functional activities, such as walking the line or stepping over obstacles that have more meaning for that individual. Some of a couple studies that I'll touch on here. The first one is a systematic review on the effects of gait, exercise on gait and postural control in patients with chemotherapy-induced peripheral neuropathy. They looked at over 1,400 studies and selected 4 and found that exercises like endurance training or aerobic training, balance exercise, and sensory motor training, changing the base of support, and like that are beneficial for people with CIPN to reduce their sway and posture and also improve their gait speed. These sessions were held on the average twice weekly, but the range of weeks that they were held was a wide range from 4 to 18 weeks for each exercise regime. And they found that a combination of activities or exercises was the most efficacious to reduce the CIPN symptoms in these individuals. Another study looked at a systematic review and meta-analysis and found that hand-foot exercises plus aerobics in combination with resistance
غير
or
اسمي شلون اغير اسمي في الزوم؟
excuse me. Okay. And muscular strength combined with balance was the most efficacious for reducing symptoms of CIPN, pain, balance, and strength. So I'm going to go into briefly one case study. This is an individual, 85-year-old, with polyneuropathy plus chronic anemia, who had a high timed up and go, 15 seconds with a single point cane, difficulty with eyes closed on both firm and foam surfaces, and a Berg where he was at medium risk for falls, and some problems with sit to stand, chair rise, 6 reps, showing weakness or demonstrating weakness in his legs. So you can see there's some changes in his skin on the ball of the great toe, which produces pain. And the question is, does tingling and numbness decrease with massage? And I have seen this guy for a few treatment sessions. This is very hot off the press. And he is already describing changes in his tingling and improving ability to put weight on his leg. But he needs some sort of pad on that first metatarsal head to improve his weight bearing onto that side. We did some ankle exercises in addition to the massage, both just kind of windshield wipers plus some strengthening. In addition, he was engaged in some static balance activities with his shoes on and off, on a pad, on firm surface, in feet together, as well as in a tandem kind of stance, and also working on single leg balance, which is extremely important, difficult for him. And then we worked a little bit on the heel toe on a 2x4 and heel rises to work on some more strengthening in a standing position and some weight shifting side to side on a platform and forward backwards. All right, so now I'm going to go ahead and turn this over to our speaker, Hadas. You're up.
Thank you, Anne. Okay, I'll go back to my presentation. No, wait. Just a second. Can you see this?
Yes.
Yes.
Thank you. Okay. So we're back to where we were, right? Yeah, cool. Okay, so thank you, Anne, for this. And really, it's great because actually what you gave us is what I like to call implicit sensory training, or the adaptive sensory motor training, which is what we do with the data for exercise for this systematic review. So thank you. That really helps. And what we will discuss now, we already discussed the chemo-induced neuropathy and what it is, and the balance training. And we'll see just a bit about sensory assessment. I'll show the treatment-induced neuropathy assessment scale, which, important to say, needs permission from the Anderson Cancer Center in Texas to be used. Okay, so whoever wants to use it needs to get permission from them. We'll talk about explicit sensory training. So if we saw the implicit now, or the sensory motor balance training, we'll look into something a bit different that I suggest and that we are now studying. And I'll show our feasibility study results and a case report to conclude. So for the assessment, I'll show the TNAS questionnaire, because I think I'll show why I think it's sensitive and it's very it is the right questionnaire or prompt to be used, and I'll talk about it soon. But before, I want to talk about sensory assessment. We can do a whole session about sensory assessment, but we won't. But the things to be suggested is to assess tactile threshold with monofilaments, with von Frey, with Sams-Weinstein monofilaments. I know many of us have all kinds of machinery that is more or less expensive, but really that is not a very expensive thing to buy. And I think we should have monofilaments in our clinic because it gives a quantitative assessment and a quantitative idea of how deep or how intense the sensation lost is. So I really suggest that, to know what our tactile threshold is for the patients using monofilaments. Allodynia we can do with a brush. There is here a brush that is validated, etc. But we can also just buy a brush in a wear store and use that. Whoever has pain because of that a brush touches him has allodynia. Okay. The NSA, the Erasmus modified NSA, was suggested for neurological patients. The problem with it is that usually our patients have only distal sensory loss, and therefore their change or their inability to sense will be only in their foot, maybe around the ankle, but not more than that. So we can use that. It gives a good idea of the foot area, and it's a good test to or assessment outcome measure to be used. 2-point discrimination for the foot is not that much, but if you the minimal detectable change there is too big for the foot. But if you want to look at the fingers, which are very important, that's a good assessment tool. And for the proprioception error, I'm suggesting a tool I made up and validated, etc. There is an article for that, and whoever wants to use it is welcome to contact me later, and I'll help you to use it. It's very simple because all you need is a piece of paper and a centimeter ruler. So it's for $50 it will go. And that will check the error of or the missed position sense for the foot, and that's a good assessment to be used. And of course, we'll do all the functional assessments, all the balance assessments, as Anne showed, Berg, or if we use, I like to use FABS for for the for this population because it's higher. Okay, so the effect, the ceiling effect will not be there. And timed up and go, and all these things that we need, 6-minute walk, whatever you want to be using, sit to stand, as Anne showed. All these we want to see. We want to see where functionally our patients are. Again, I'm not talking about blocks and things for the hand, wolf, whatever. We're talking about the lower extremity in this specific session. The treatment-induced neuropathy assessment scale, again, needs permission from the Anderson Cancer Center, but that's not very expensive, and I think it's worthwhile. It's a patient-reported outcome measures, which gives us quantitative and specific knowledge about our patients' symptoms and about their function regarding to the sensory loss of their feet. It is sensitive to change. It goes from 0 to 90. So the change can be, if someone is 80, as higher as it goes, it means that the person is has harder symptoms. And really, if someone goes down from 70 to 40, we can say there's a big change or that. It addresses the last 24 hours, which has pros and cons, because if I had a very bad day or a very good day, it still doesn't say what it is, but you know, that is the tool. So let's see, it looks at symptoms, okay, not present in 0. So I guess many of us, if we don't have neuropathy, we will have a score of 0. And as bad as you can imagine is 10. So if it gets really, really bad, it's close to 90. Numbness in arms and legs, tingling in arms and legs, pain in arms and legs, hot and burning sensations, and feeling of coldness. These are the symptoms. And then how the neuropathy symptoms interfere with life. Difficulty using the hands, trouble walking, trouble to balancing or falling, or a falling sensation, or afraid of falling, and disturbed sleep. So really, it touches these things that we have. It looks at hands and feet, and it gives us a good opportunity to look at how these symptoms interfere with the patient's life. I'll say that patients of mine and patients in our study that have filled this have said that it's the first time anyone has asked them about it. It's the first time anyone has really looked at it, and they were really happy to fill it in, only for the fact that someone is looking at them and asking about these things. So that's very important, even in that regard. It opens the conversation about it. Again, the treatment objective is, if we go from, okay, we did a very short thing about assessment, and we talk about treatments. So our objectives will be balance, will be walking, will be quality of life, will be going out of the house to the shop to get groceries, whatever. And even this, I'm going back to this patient, because if he can carry on sleeping next to his wife, that is amazing if we accomplish that. I think what we're looking at, we always look at motor output and the sensory experience, and we want to use as much of the sensory capacity that the patient has. Okay, we are not fixing the dying back neuropathy. We can't fix that, but, or at least not with physio, at least not by what we know right now. But I want to suggest using attention or using top-down treatment or thinking to enhance sensory capacity and to use as much sensory capacity that the patient can use. So really all the what I call implicit sensory motor, okay, all the things that Anne showed that are great, okay, in her case report, and all kinds of repeated exposure, tense, massage, etc., are great. I'm going to talk about explicit sensory retraining or discrimination training. It has a few names where I can do the tactile thing. Okay, the patient can, I'll show in a minute what we do. It can be tactile, it can be proprioceptive, it can be temperature, etc. So what are the steps, or what do we actually do? What did we actually do? This is a protocol we use. You can do your mix and match by what is right for your specific patient, but we are training detection, training touch detection, training texture detection, training temperature detection. I can hear, I'm taking this freezing thing from the freezer, and I'm touching, and I'm asking my patient with eyes closed, tell me when you feel that I'm touching, or am I touching you now or not? If I touch a small portion or a small area of his foot, maybe he won't feel. Maybe if I touch all of it for, I don't know, 10 seconds, he will feel. I will find the place where my patient feels and will begin there. Will try to feel more proximal, to understand what the idea is, to understand what he's supposed to feel, and then go back and forth. We'll see in a minute the stages and what I suggest. So we can do detection. Do you feel or don't you feel, with different sensory modalities? We can do discrimination. Is it the same or different, or quantification? Okay, I have this freezing thing, and I have just a cold thing, and I have a lukewarm thing, and I have a warmer thing. Can you tell me which one it is? Can you quantify them? The same with proprioception. I can put the foot on the floor or on the very high step, and then we can go with shorter distances and try to detect them and try to discriminate between them. And we can do object recognition. I know usually we think about object recognition or about sterganosis with our hands, but our feet know very well which part of Lego we stepped on when we walk into the kids' room at night. So we have a very good recognition with the foot as well, and we can do that and really enhance sensory ability that way, because it's more interesting. Maybe it's more of a game. Let's see which one it is. I have 3 different types of balls. Which one is it? Or is it the same one, or is it 2 different ones? So here I have a patient with 2 mats or 2 cloths. One is wet and one is dry. Think how, even if you have just a little bit wet spot in your sock, you already feel it, right? I just walked on a very small spot that was wet, and that minute I feel it. So if we can, which one is it now? Close your eyes, see which one it is. Is it the dry one? Is it the wet one? Okay, we will select the modality. Right now it's wet or dry. It could be soft or hard. It can be warm or cold. It can be up or down, or dorsiflexion or plantar flexion. So it can be of any modality. I can select the modality I'm using, or the stimuli I'm using. We'll do an attentive exploration. We'll talk about it. We'll think how it will be like. We'll get calibration from proximal areas which feel correct, which are normal, and we will say what it will be. Okay, we'll put the foot on the floor. What will you feel? I'll feel that it's cold because the air conditioning on. Okay, we talk about it. We anticipate the sensation, and we repeat it in progress. We go, and this is what we do with any kind of training. So we begin at the point where it's not too easy, but it's not too hard, and we progress. We use more proximal areas. We use vision. We can look. I can look and feel and look and feel and do this calibration thing. And if I use many types of modalities and many types of stimuli, we can transfer them. We ask ourselves if explicit sensory training is effective in the treatment of CIPN. We know it's effective in stroke. We know it's effective in multiple sclerosis. We know it's effective in CRPS. Is it effective in CIPN? Is it effective for chemo-induced peripheral neuropathy? So we don't have answers for that yet in literature. So we went and did a feasibility study. We did a screening. We had a first session of introduction and assessment. Then we had 3 sessions of training, 3 one-on-one sessions with a physiotherapist, a week apart, and we gave them home practice. We'll let them use at home, use 2 different balls and try to feel them. We told them to try to feel the edges of the floor. Like if you have tiles at the floor, feel the edge, see if you felt the edge, look at it, close your eyes, go to the other edge, see if you got it, etc., etc. And the last session again was assessment. Okay, these are our participants. You can see that they'll relate to your patients by age, by type of oncological diagnosis, different types of cancer, by chemotherapy type, and by time since last chemo. We took only people who had last chemo from 3 months up. Male and female, so we had 12 participants, and the satisfaction rate was 82 and a half, with the main dissatisfaction was over the home exercise. So for the next study, we'll do a better one, more specific, really protocoled, and the number of sessions. They wanted more, which means they thought it was a good treatment for them. We had no dropouts, no no-shows, and we wanted them to do more than 10 minutes per day, but that's what we got. There was a stable baseline, so really for the VAS, for the TNAS, for the timed up and go, there was, we checked the baseline pre-treatment, and they were chronic, and there were no changes from one assessment to the other before treatment. And then we can see that we got their pain down by 27.5 out of 100. So that's almost 3 out of 10, okay, 30 out of 100, with pre-post being significant. These colors show the individuals, the different individuals, each of the 12. And we can see how pain went down from the different sessions. The treatment-induced neuropathy assessment scale did not go down as much. It was not significant. It went down by 13, maybe because we did not treat hands, and the TNAS we saw has hands in it too. Maybe because we did not change sleep disturbances, but still there was a change. Proprioception with the lower extremity position test went down. The error went down from more than 2. We can see the right foot and the left foot here, to less than 1. So they went down to almost normal, or even normal. Timed up and go, they had went down minus 4 times 7. We can see here the different individuals, that some of them, if we look here, from more than 30 seconds down to less than 15, or others, we can see here how much timed up and go went down. They had a median of 14, and they went down to a median of less than 10, which is normal. The Fullerton Advanced Balance Scale went up. 40 is the most, so it went up. 25 is the cutoff for falls, for fall risk. So as a group, they went from under or into fall risk, out of fall risk as a group, and it was significant as well. And I want to show a case report in the few last minutes before we open for questions. A female, 72 years old, with cervical cancer, 10 months after chemotherapy, lives on 2nd floor, treated by reflexology and acupuncture, no physical therapy. She arrived accompanied by a granddaughter. She did not go out alone. She complains about her feet feeling like cotton-like sensations. We'll see that a lot with pain and swelling. She can walk up to 30 minutes, not every day. She manages stairs with handrail. She can stand in the kitchen, but not daily. Some of the days she can't. She has no history of falls, but she's very, very afraid of falling. And what she really wants to do is to be able to go to the grocery store and go back with, I don't know, 5 kilos, 2.5 in her hands, with some milk and whatever, back home to walk independently. That's her goal. After 3 treatments, she feels more secure. She comes unaccompanied without her granddaughter or anybody else. Sit to stand was without difference, but she is able to carry 5 kilos grocery bags. So she got her personal goal. She stops because of cardiovascular reasons with walking, by what she said, and she began to exercise. Somehow this physio, so we can't really say, is it the physio itself? Would anything do it? Or is it this treatment per se? But we think at least the sensory treatment did the change. Pre-treatment, her TNAS was 78 out of 90, and she goes down to 35. A maximal pain goes from 6 to 4, average pain from 4 to 3. Her tactile threshold is better, but still out of the norm. The EMNSA, as I said, will not change that much because it's only in the feet. She does not have loss in her leg and thigh. Time down and go went from 15 down to 11, and the FABs went up from 8 to 19, which still puts her in fall risk, but she feels so much better. Thank you very much. This is the Shamir Medical Center, and this is my beautiful college in Tzfat in northern Israel, and may we pray for peace, and I'll stop sharing. It will be time for questions. Back to Sophie. Thank you.
All right, thank you both so much for all that valuable and important information. For those of you who have questions, feel free to post in the chat. We'll kind of go through it. Or feel free to raise your hands and we can invite you to come onto the mic. So Hadass, I don't know if you saw that question there. It says, could you please explain how to properly perform and assess the lower extremity position test?
Okay, first of all, there are 2 articles that we published, so you can find them online and have them, or write to me and I'll send them. If I have a paper, it should be nylon, because otherwise you get stuck with it, and with a sock. So the foot can move. You move the patient foot to a point. I have there 2 lines, so I can choose any, so the patient doesn't know which one, but you can also make other lines. I bring the foot passively to a point and I take it back. And then I tell the patient he or she need to stop at the same point. And we validated it with young people and with older people who were healthy. And the cutoff with a young were not more than 1. And with older adults, 60 and up, not more than 1.5 error. And we tried it on stroke patients, and they had the more affected foot had big errors, and then the other one had no errors, and we saw a change within treatment. So it was sensitive enough to see the change. The idea of passive, it's built on an assessment tool by Winnie Dunn, which was done for the hand. She did it after Jane Ears, and she published that, but she did it actively. And I wanted it to be good for patients who have motor problems or spasticity and or paralysis and who can't move. So that's the reason I did it passively, and I think it's better.
Great. Karen has a question that says, do you use the ABC scale for pre and post treatment?
ABC? The active balance scale, that one? The questionnaire, I can't see the question.
Sometimes I will use the ABC, but I usually streamline it and ask the first question, how confident do you feel in your balance? And on a zero to 100%, it takes a lot less time, and that way they can just cut to the chase about their balance confidence. And so that is useful in anybody with balance dysfunction.
All right, there's a question that says, you talked about the up to down or down to up strategies to sensory retraining. Can you explain it with more detail?
Sure. When I use all the things Anne showed, which are great, have a bottom-up way of, I have a sensation going up and I need to adapt, I need to react, okay? That would be bottom-up. I get a stimulus or I get a activity, movement, balance, something, and I need to react. That would be bottom-up. What we do with a top-down is that we think about, we discriminate, we detect. I'm aware of, or I do attention or awareness training of the sensation. I don't know if that helps. With the short time we have. And I think in the clinic, or not I think, I do in the clinic, I do both. But the thing is that many of the chemo-induced neuropathy patients, they'll say, I don't feel my feet. And you want to show them, it's true for stroke patients or whatever too, you want to show them what they do feel. It's like, I can't run. Well, let's run 10 seconds. Can you run 10 seconds? Yes. Okay. So then we'll slowly add something to that. So it's the same with sensation. It's not I feel everything or I feel nothing, unless, there's a spinal cord injury. But most patients will not have complete anesthesia. They will have hypoesthesia. And then we can see and augment that slowly.
All right, Sally has a question that says, any experience with the use of menthol cream for CIPN?
I will use some natural kind of creams, just a nice massage cream, or you can get some creams with essential oils. Once again, we're not necessarily curing per se, but we are making them more aware of where their feet are. That would be more topical. And I agree with Hadass that we can, while we're doing the implicit training, we can ask them to think about what does it feel down in their feet, ankles, hips, knees, so they can get both cognitive aspect as well as the sensory aspect of what's going on. And in the patients that I've treated and used these creams on, I will then follow it with working their balance barefoot and also with their shoes on, because that is real life. They are going to be working, they're going to be moving around in both situations.
All right, Nicola says, I thought I had read about active range of motion exercises to help blood flow and flushing out chemo to help CIPN.
Active range of motion? I'm not sure what that means.
Well, one of the things that people need is they need to be able to work on flexibility of their ankles, hips, knees, so that they don't tighten up in the muscle groups that are possibly weak, possibly tight, and then lacking the sensation. So keeping the range of motion is important in a sense, but it's just one aspect of the whole, I think, package, because you want to give people a combination of approaches that would be helpful, as Hadass pointed out so nicely.
All right. Have you utilized vibration, whether local or whole body, to address sensory issues in your research or work?
I don't use vibration. It's very common. The full body vibration is very in Southeast Asia, I think. Interesting if it came from there. Vibration is a very good tool. So I think like we do detection of cold, or we do detection of I don't know, a turf platform, or anything that augments sensation and that gives a stronger sensation, then we can use it. So if vibration, if you have a vibration tool, I don't think it's great. But I don't know that specifically vibration is better than any other modality necessarily.
And there's a lot of people that I work with, just to tag on here, that will use the vibration plates. You have to be careful of the intensity, and how much input they give in terms of the therapeutic dose. But it's not just a one-stop shop. It's a combination of approaches. And some people believe in that vibration plate and think it does help them. So if that's the case, then as long as it doesn't hurt them, it is a possibility. I've had people react both ways. So as a positive, and others that just don't like it.
Couple more questions here. Do you work with balance training during chemotherapy time?
Yeah.
Absolutely. As long as the patient's fatigue level allows for performing the different activities, we can modulate the, once again, treatment dose, give them more frequent rest breaks, give them a chance to feel what's going on in terms of, their sensory organization, and so that they can begin maximizing their balance repertoire. But everyone is different. Once again, it's going to depend on how much the energy level they have, but it is good to do exercise as tolerated during chemotherapy sessions, concurrent with their treatment.
And last one here, you may have touched on, but for how long do you support balance training as pre-CIPN as prevention with neurotoxicity?
For how long? I don't know, I think all of us need balance training for all of our lives. I believe if we get the chance before chemo, sometimes, you have you don't need to begin today. So if someone sees physio even before chemo kicks in, that's even better to do a something for people to know what they'll need to do. But it's an ever-going training thing for all of us, with chemo and without.
I did not report this in my talk, but I agree with Hadass. It's sort of a lifelong event in terms of balance training and retraining. We did a 250-person study on people that were undergoing chemotherapy, and those that were caregivers, as well as those who were post-chemotherapy. And we found that nearly everyone improved their balance, and this was measured on a balance machine. So yes, it is efficacious, and we know we all probably need balance work. And that, I tell people they're going to do their balance retraining and that whole program, holistic program, for the rest of their lives. And I get a funny look sometimes, but it is, to me, the truth. So as much as you can encourage people to do this and integrate this in their day in and day out activities, that is helpful, I think.
Another question says, did you treat CIPN patients differently for those with CIPN and diabetes, or treatment approach work for both fairly equally?
Oh, that's a great question. It has not been studied. So maybe whoever asked that, that's your PhD. I'm sure balance-wise or all the, what I aim as implicit or as bottom up or balance training, that is good for everybody. So for diabetes, neuropathy, just as much as chemo-induced neuropathy. For the explicit things that I showed, nobody has tried it yet. So I can say that I would try, and I would be very happy to co-work with anybody who would do the study.
Yeah, you may have a new PhD student. This person says they are a PhD student. So there you go. Because I think it's going to be hard to differentiate between what part of the CIPN is the chemotoxicity versus the diabetes, but maybe there are some ways to do that in terms of nerve conduction velocity tests and following them more long-term, longitudinally.
Nicola wants to know, what was implicit balance training again?
Again, it's my way to put it, the implicit versus explicit. Explicit being the talk about it, let's talk about it, attention, awareness, the cognitive part within the sensory and sensory motor training. So the implicit would be, I'm not talking about it, we're just doing it. We're standing on a wobbling board, we're walking on turf, we're doing the step over step, whatever. And the explicit would be really the discrimination training, the detection training, the sensory awareness. And as Anne said, if I massage a patient's foot, that would be implicit. And if I ask him to say if it's the big toe or the little toe now, or if it's the heel or the front foot, the forefoot, then that would add in an explicit element to it.
And what is the time per day that you ask patients to do the exercises? Is there a specific daily time needed for benefits?
Is there for balance training?
Is there a magic number? Well, one of the studies suggested that, this is going to be about 15 to 30 to 60 minutes a day. Some of the studies varied widely, right? Let's be real. As Hadass found out, not everybody is real adherent to exercise programs. So working on integrating this into their day. So I will say to people, when you're getting your coffee, work on your heel toe, work on feeling your foot on the ground, or single leg balance, or whatever the case may be, but giving them little pieces of that 10 minutes 3 times a day adds up to 30 minutes, which is a really good rounded number. But there is no absolute magical number. Like I said, the studies really vary quite widely. To be an expert, you need to practice, though. So people ask me, does this really help? And the answer is, well, it's better to practice it than not. You're going to be further ahead in terms of these practice opportunities and looking at it as an opportunity rather than maybe an exercise. Maybe we'll call it an activity that they can integrate into their day. And by the end of the day, they've been able to accumulate a lot of experience. Does that answer your question?
Also, if I can add, we have seen with constraint-induced therapy, for example, that they started off with 8 hours per day. So they took only people who can really work 8 hours per day. but that nobody can do in the clinic. It's not cost effective. It's not relevant for anything. So they went down to 2 hours, and now GRASP says 30 minutes. So we need to do as much as the patient. We need to understand that these are sick people many times. Some of them are post-cancer, but some of them are really sick. And for that, I think the ability to sit with a bag with a few balls and some cups and just say, you know, do 5 minutes of training, and then in the afternoon do 5 times of training again, or when you go into the bathtub, feel the floor, feel when it's dry, and then feel when it's wet. That puts the training into the day's routine, so that works with the explicit training as well.
Awesome. Thank you, guys. That is it for questions. So just a reminder, this recording will be posted on our website shortly after. But yeah, thanks again to Hadass and Anne for all the information. Great webinar.
And thanks for Helena and for Sophie for organizing this and for being.
Yes, and thank you for everybody being here, and it's great to see everyone.
Good night here in Israel.
Good afternoon here in San Antonio. Adios.
Bye.
All right, very good. Thank you all. You're still recording, Helena.
Yes, I'll close the recording.